Okay, let's dive right into this explainer. Today, we're looking at the human body's absolute ultimate fortress, the skin. As healthcare professionals, you're essentially the frontline commanders, tasked with defending this fortress. You know, when it's intact, it repels invaders seamlessly, like a well-oiled machine. But when the walls are breached, well, the clinical management of that site becomes a high-stakes battle to restore order, prevent infection, and really orchestrate that healing process.
So, here's our roadmap for today. We'll be looking at your body's ultimate fortress, threats to skin integrity, the art of wound assessment, cleaning and dressing wounds, and finally, advanced healing with NPWT. Section 1. Your body's ultimate fortress, understanding skin anatomy.
Now, this wall we call the skin, it's highly active. I mean, it's not just sitting there. It regulates our temperature, synthesizes vitamin D, and gives us our sense of touch. And for immune defense, your skin is actively guarded by Langerhans cells. Think of them as the fortress guards. They recognize invaders on the spot and produce antimicrobial peptides to fight off pathogens. It's just a brilliant, totally self-defending structure.
And this brilliantly illustrates the core concept of our work today, skin integrity. Basically, this is the state of the skin being whole, intact, and completely undamaged. It's our first line of defense against environmental hazards. When it's intact, the fortress holds strong. Maintaining this state is the absolute foundation of overall health. But hey, as we all know in the clinical setting, maintaining this perfect integrity is way easier said than done, right?
All right, Section 2, Threats to Skin Integrity, when the fortress is breached.
Even the strongest walls can be compromised. Let's look at the specific enemies that cause these breaches, which are so often brought on by things like aging or immobility. First, we have pressure ulcers. This is where prolonged pressure literally starves the tissue of blood flow. Then there's maceration from excessive moisture breaking things down, excoriation from mechanical scratching, and of course, severe skin tears caused by shear friction or blunt force. Every single one of these is a physical breach, a wide open door where bacteria can just waltz right in.
Of course, it's worth noting that not all breaches are accidents. We actually categorize wounds into two main types. Intentional wounds are systematic therapeutic traumas. Think of a surgeon making a really precise incision, or even just a simple venipuncture. In these cases, we control the environment. Unintentional wounds, on the other hand, pure chaos. These are your accidental traumas, the collisions, the unexpected fractures. And here's the key takeaway. The way a wound is acquired drastically changes how we expect it to behave and heal.
Now, what's really interesting about this is the stark difference in how we classify contamination. At the top, a clean wound is typically closed, uninfected, with no tract entry. But drop all the way down to dirty or infected. Here, the fortress is literally completely overrun with dead tissue, purulent drainage, and clinical infection. It requires immediate, highly targeted treatment to salvage the site.
So imagine you walk into a patient's room. The fortress is breached. You see the wound staring right at you. What is your very first clinical move? Do you immediately grab a dressing? Do you just start scrubbing and cleaning? Actually, no. You need to gather intelligence first.
Which brings us to Section 3, the art of wound assessment, evaluating the damage.
Before we can rebuild the wall, we have to conduct a strategic reconnaissance mission. And the crucial point here is knowing exactly what to look for. We measure the size, the dimensions, the depth to establish a solid baseline. We really scrutinize the wound bed appearance. Ideally, we want to see that bumpy red granulation tissue, because that tells us, hey, healing is actively progressing. We also have to evaluate the exudate, the fluid oozing out. A little bit, totally normal, but excessive or off-color exudate, that's battlefield debris pointing straight to infection. We also check the edges for undermining or tunneling, plus the condition of the surrounding peri-wound skin. Pain, odor, foreign bodies, honestly, every single detail tells a story.
Section 4. Cleaning and dressing wounds, restoring the barrier.
All right, let's break down these meticulous clinical guidelines into 3 logical phases to restore the barrier. Phase 1 is preparation. Before you even touch the patient, you collect every single sterile supply you'll need. Gauze, cleansers, dressings, the whole shebang. Why? Because leaving the room mid-procedure totally compromises your sterile field. You relentlessly wash your hands to ensure you aren't the one accidentally introducing new invaders. Then you explain the procedure, gain consent, position the patient, and finally suit up in your gloves and PPE.
Moving on to Phase 2, the action phase. You carefully remove the old dressing and dispose of it right away. You do your quick assessment of the size, depth, and drainage, and then you irrigate. Now look at Step 3 here. It is absolutely vital. You always irrigate gently, from the least contaminated area, which is usually the center of the wound itself, outward to the most contaminated area. You never, ever want to wash bacteria from the outside skin deeper into an open wound bed. After that, you pat the wound and the surrounding skin dry with sterile gauze to prevent that nasty maceration we talked about earlier.
Finally, we hit Phase 3, restoration. This is where you apply your prescribed topical medications to deliver that targeted treatment. Then, you place and firmly secure your new sterile dressing. You've effectively just installed a brand new temporary barrier. Afterward, you dispose of your PPE, thoroughly wash your hands again, and, critically, you document those findings. Oh, and don't forget to educate the patient on what's going on.
Section 5. Advanced Healing with NPWT, High-Tech Fortress Repair.
Let's move to and see how this builds into our high-tech fortress repair for those really chronic, stubborn wounds. We're talking about negative pressure wound therapy, or NPW. Basically, this is a specialized treatment where we apply controlled negative pressure. Think of it like a gentle, continuous vacuum, directly to the wound bed. It actively pulls away excess fluid, it reduces swelling, and it mechanically draws the edges of the wound together to promote the rapid formation of new tissue. It's a real game changer.
Applying NPWT is for sure a highly advanced skill. First, you assess the wound and debride any necrotic tissue. Then, we precisely cut a sterile foam or gauze to fit perfectly inside the wound and seal it with a transparent film so it's completely airtight. Once we connect the tubing and program that prescribed negative pressure, the machine goes to work. It acts like a high-tech assistant pulling the tissue back together. From there, your job shifts to regularly monitoring that system seal and keeping the patient educated.
So, from understanding those microscopic guards in the epidermis to mastering the complex steps of irrigation, all the way to high-tech vacuum therapy, you now have a really complete, structured view of wound management. The skin truly is our ultimate fortress. Now that you hold the clinical blueprint, how will you defend it today? Thank you so much for joining me for this explainer, and I'll see you next time.